welcome everybody to the final meeting for 2020 in this COVID year of the Yarra Drug and Health Forum. My name is Peter Wearne and I'm the chairperson of the Yarra Drug and Health Forum, and on behalf of the forum I'd like to welcome everybody today. I'd also like to, on behalf of everybody in the meeting, from wherever you are meeting, we are meeting on First Nations land, no matter where we are. And I'd like us all to acknowledge whatever country that we are on, acknowledge the traditional owners of that country, and pay our respects to both elders past, present and current, and to acknowledge the enormous contribution that those cultures and those peoples have made to the land, the culture, the spirituality, the environment, and the ongoing evolution of the land that we live in. And we would like to see a day, I think, when there is true reconciliation and acknowledgement of those contributions and that prior guardianship and occupation, both legally, constitutionally, and culturally within Australia. And so we look forward to a day of true reconciliation and true acknowledgement. And we also acknowledge any Aboriginal or Torres Strait Islander people that are in the meeting today and pay our respects to them. And just on another note, I just want to also acknowledge the growing awareness and sensitivity we see in different parts of our community about the place of First Nations people and culture within our society. And although I'm not a rugby fan, I did hear the attempt of the Australian rugby team to sing a chorus of the national anthem in a First Nations language on the weekend. And the intent, I think, was fantastic. And it's great to see that people are starting to become far more aware of the need to be more and more understanding of the role and the place that First Nations people and culture play in this country. Anyway, so today we're looking at a really important sort of ending of the year event for us, and that is we've had a theme this year of thinking about 35 years of harm reduction in Yarra. And COVID-19 has presented some enormous challenges in terms of COVID-19. And we would hope that it's been a time where we've all paused to reflect on what harm reduction means going forward into 2022 as we come 2021 as we come out of 2020. And we've got some fantastic speakers today. We've got Dr Nick Thomson, who's been a friend of the Yarra Drug and Health Forum for many, many years. Dr Paul Dietze, who likewise has been connected to the forum for well over 15 years, and also Mr Gary Morris from the Department of Health and Human Services, from the Drug Policy Division of the department, who's going to be talking about the department's work in harm reduction and reviewing and thinking about how practically the department rolls out more initiatives around harm reduction in an attempt to really save more lives and really progress the role of harm reduction as a policy and practice framework within the community. So we're going to jump in straight away, and I'm going to introduce our first speaker. The way we're going to conduct today is we're going to have three speakers, about 15 to 20 minutes each they're going to speak for. The first is going to be Dr Paul Dietze. Paul's going to speak, then we're going to have Dr Nick Thomson, and then we're going to have Mr Gary Morris from the department. And after that, we're going to have questions. The questions can come via the chat room, and that's probably the best way to do it. I think we do have a facility at the end for people to ask live questions. You can turn your cameras on or off, that's up to you, but we would prefer for you to have your microphones off at all times unless you're invited to ask questions, if that's okay. Okay, let's get underway. So I'll introduce Paul. Professor Paul Dietze is one of Australia's leading. Whoops, I just lost. Paul, can you just take down your? Oh, crikey! I've lost your bio when you did that. Well, Paul's been working at the Burnet Institute for many, many years. And Paul's been a leading epidemiologist and researcher around harm reduction. He had a stellar career at Turning Point when Turning Point was first started in the 90s, and has been not only an Australian and Victorian leading expert in harm reduction and thinking about harm reduction at a state and national level, he's been an international leader in thinking about harm reduction. And there are many things that Paul's led in thinking about how best to. And so it's with great pleasure that we invite Paul to speak to us today. I hope that covers you with the due respect that you deserve, Paul. So welcome, Paul.
Thank you very much, Peter. That's very kind of you, and sorry for sort of screwing around the screens. I'd like to acknowledge that I'm on Wurundjeri country that's not been ceded, and acknowledge elders past, present and emerging as well. Thanks for the invitation to come and speak to you all today. It's always great to have an involvement with the Yarra Drug and Health Forum. We've done a lot of work together over the years, and I think achieved some real outcomes and benefits for the Yarra community, as well as the sort of Australian community more broadly. So I'm going to be talking a little bit about some of the stuff we've been doing to measure impacts of COVID-19 restrictions. As you can see from the title there, hopefully everyone can see the slide properly and it's not the outline view. Can someone nod their head that it's the right view?
All good, Paul.
Thanks. So basically, in March, we became aware of the potential impacts of SARS-CoV-2, the virus, and COVID-19, the disease. And Amy Peacock and I wrote an editorial for Drug and Alcohol Review where we spoke about some of the issues that we could expect to emerge on the basis of the sorts of things that we've known from the past. And, ultimately we're basically just saying that, COVID-19 restrictions, because of the restrictions on travel and so forth, really we would expect them to disrupt drug markets and change patterns of drug use and sort of change the way people access and use treatment and harm reduction services. It's obviously a much more sophisticated argument in the editorial than that, but that's the take-home message. And part of that was connected just to the way in which our borders operate. So if the borders are closed and the police intelligence is correct, then basically all the heroin that comes into, or just about all the heroin that comes into Australia would be unable to come through, because the argument there is that most of it comes through passenger aircraft. So with them gone, one can imagine that there'd be some pretty big impacts. Luckily, we have a whole series of different studies out in the field that do different types of illicit drug surveillance. So we've been running the illicit drug reporting system, the IDRS, for a long time. It's annual face-to-face interviews. We've got a similar study called the Ecstasy and Related Drug Reporting System. Again, that's been going for a long time. These are consumer interviews that we do in these studies. We recently established the NSP Snapshot Survey with a group of services in and around Melbourne, which is essentially a series of rolling snapshot questions of NSP clients. And then we have 2 prospective cohort studies that have been established for some time, and we follow up the same people every time. So as opposed to the first 3 columns in that table, with the VMAX and Supermix, we actually follow people up over time, and we can look at what impacts they've had directly on those people and see within that person whether or not there's been any changes. So it's pretty sophisticated, whereas everything else is really just a single snapshot or a cross-section, and so you don't know how much of it's due to sampling, how much of a change might be due to sampling error and so on. So, basically all of our studies involve some kind of data collection with annual questionnaires or something like that. We generally ask about things like drug use history and patterns of drug market access, what sorts of treatment services people are accessing and so forth. We do collect some blood samples from some of our studies. And in some of our studies, we have data linkage, so we can look at what people's use of GPs is like, for example, with Medicare Benefits Schedule, MBS, or Pharmaceutical Benefits Scheme, PBS data, and a raft of other data sets that we can look at to try and look at what sort of patterns have taken place. And some of the useful information that's come in relation to that is, we, for example, were able to show in our cohort of people who inject drugs that when the supervised injecting room opened in Richmond, there was a big drop-off in the number of overdoses that were attended by ambulance in the cohort for those who've used the facility frequently. And that was one of the key data points that the review panel worked with when making recommendations about the continuation of the facility. These figures would be pretty familiar to people. So this is just an outline of the Australian COVID epidemic, and you can see when restrictions were introduced, and you can see across the top there when the EDRS surveys were running, when the IDRS surveys were running, for example, and all through this period here, we had Supermix and VMAX, our prospective cohort studies, running. And so we can actually look at what changes were taking place by doing a serial analysis of what was happening over that time. I'll talk quickly about some of the initial findings we got from Supermix. We've got a lot more data than what I've been able to present today, but we haven't gotten around to analysing yet, which is a frustration, but we are about to appoint some new people to help with that work. For those of you who don't know, Supermix is really just basically trying to determine trajectories of injecting drug use. We've recruited people from across Melbourne and now into Geelong as well. We work with a range of fantastic services who really help us out trying to recruit people in. And we follow people up every year, and we also look at what changes might have taken place in things like ambulance attendances and things like that for them. And this is what the initial analyses showed. So, not surprisingly, when there was changes to government benefits and so forth, we saw an increase in the number of people reporting an average weekly income above $600 a week. We saw no real changes in employment or anything like that. We saw a decrease in unstable accommodation here, which we can attribute to things like the hotel program and so forth. And we started to see some actual improvements in things like mental health as measured through this PHQ SADS there. Didn't reach statistical significance, but it's kind of an interest that sort of thing was starting to happen. Sorry, that didn't flick through for some reason. In terms of sort of basic drug use and drug market indicators and so forth, there wasn't really many statistically significant changes. We started to see an increase in the price of heroin, but a lot of variation there. Increase in the price of methamphetamine, a lot of variation again, so these weren't coming up as statistically significant. But one thing we did see is that people reported injecting a lot less frequently. So the number of times they injected per month before COVID was around 20 on average, whereas after COVID it was around 12. So that's that's a pretty big change. And I haven't got it in this table, but we also saw people reporting that their injecting networks had shrunk, which isn't surprising because people were being expected to stay home and so forth. This was only for essentially lockdown 1.0, not lockdown 2.0. As I said, lockdown 2.0 analyses are coming. If you now turn to VMAX, VMAX is really interesting because we also have data from not just Melbourne, but we also have 3 regional sites in the VMAX study. And VMAX is looking at methamphetamine use and methamphetamine smoking in particular. So it's not just about injecting in this study. And again, we saw some pretty interesting changes. So we saw this increase in income. This is again in lockdown 1. We saw a decrease in employment. So fewer people said that they were employed. Accommodation status in this cohort didn't change so much, and it's partially because this cohort is not necessarily based in inner Melbourne and so forth, and so there's no people in regional homelessness is kind of is obviously a significant issue, but it's not as prevalent as in Melbourne, or at least in our samples. We did interestingly see few changes in relation to some mental health measures that we had, which really didn't change before and after COVID. And that's partly because they're already scoring pretty poorly on these measures. And so they're already experiencing pretty significant mental health issues. And then the sort of distress that the rest of the community is experiencing, there really wasn't a chance for them to experience any more distress because they're already distressed, if that makes sense. But if we turn to some of the other measures, this is some interesting things here. So we saw a decrease in methamphetamine use in the cohort, but that wasn't offset by an increase in cannabis use. If anything, it declined a little. Alcohol use also declined a little. But those who were using methamphetamine were paying significantly more for the methamphetamine that they were consuming when they were purchasing a gram. So we are seeing some of those market effects that we were expecting to see. So increase in prices, and at the same time, people reporting generally, sort of anecdotally, that the quality of the drugs that were out there was worse. So now I want to turn to another little data set that we've been collecting for some time now, and I want to pay special tribute to the services that are involved in collecting these data. So a number of the needle and syringe programs around Melbourne. And so in June 2020, we asked a series of questions of people who were coming into the services. And, just looking at last drugs injected reported by people and so forth, and you can see that most people in the sample reported injecting heroin most recently. And since the epidemic had begun, a few people thought drugs were easier to access, a few people thought they were harder to access, and 56% thought that access had basically stayed the same. And I must say, this kind of message of sort of some people finding it easier, some people finding it harder, and basically things staying the same is pretty similar across the country for a lot of the different measures that we have. And then, around about 23% had been tested for COVID, which is interesting at that early stage. Testing wasn't anywhere near as frequent as it was during lockdown 2. And only about 12% reported that they'd had difficulty accessing healthcare when they tried. So, I mean, that's encouraging, although obviously you don't want to be one of those 12%. But what we did in the next round, in round 3 of this study in October, we started to ask a few other questions around policing in particular, which I'll come to in a minute. We asked about whether or not people's drug use had changed, and you can see that 11% reported that their use had decreased a lot, 20% decreased a little, 16% increased a little, and 8% increased a lot. So again, that varied picture of sort of some people experiencing a decline, some people increasing, but still most frequently people were saying that things were pretty stable. You can see the distribution here. Most people were coming from St Kilda, substantial numbers though from North Richmond and Healthworks and Braybrook. But the big thing that we found, which was troubling, was this. So around about 24% had reported that they had experienced interactions with police. So only about 5% reported that nothing had happened of those of the overall sample. About 7% were issued with a warning. But there's this considerable number who were fined for breaching curfew or being out of home for a non-essential reason, not being within 5 kilometres of home, not wearing a mask. And then some people even reported that they were arrested. So this is quite troubling. 3% or more, so a minimum of 3% of these clients of needle and syringe programs have been fined. And that, roughly translates into something like 18 times the rate of the Melbourne population more broadly. And these are obviously people who, as we all know as a sector, have limited capacity to pay. So it's considerable, so we are quite concerned about that. And this information has been fed through to DHHS and to Victoria Police and so forth, and local area commands of Victoria Police have been informed of it, and there is sympathy towards sort of improving practice around it, but obviously it's coming quite late, and it's obviously more difficult to be fined nowadays as many of the restrictions have been eased. But hopefully it'll feed into some ways in which people can challenge some of these infringement notices. One of the things that's been really impressive is the way in which drug treatment has pivoted in Australia in response to COVID. There was a fantastic article in Harm Reduction Journal led by Adrian Dunlop and others, just talking about what sorts of changes needed to be made, and that's been followed up since. And you can see sort of the key, one of the key treatments that we were concerned about was people who are on opioid agonist therapy. And, a lot of people had appointments moving to video conferencing, as you might expecting, but treatment satisfaction remained mostly unchanged, and only 9% reported difficulties accessing treatment. And this is of people who inject drugs who were interviewed as part of the illicit drug reporting system, I should have said. And most people who were on opioid agonist therapy reported no change in the key features of their treatment. Some people reported increased takeaway doses and so forth. Some people report the dose had increased and so forth. But, basically most people are in this purple zone that no change had occurred, which is, encouraging in terms of treatment continuity, which is one of the big concerns that we had. So to sum it all up quickly, really there hasn't been that many major changes noticed in drug use or purchasing patterns. We do notice this injecting frequency decline, and then in other groups of people who use drugs, there has been some really big changes. So people who use drugs socially, so people who go to music festivals and so forth, really have reported big drops in their drug use, because their drug use is very much more a social kind of thing, and with the limited social interactions allowed, obviously we're going to get an impact. Seen some changes in demographics and small changes in improved mental health for people who inject drugs. Big thing is this big change in income, and importantly we saw that improvement in housing status for some people. So we've seen increases in price of methamphetamine. With that last slide, I think we've seen that the service pivots that have taken place have worked effectively. But we have got this concerning enforcement of lockdown restrictions on some of the most vulnerable people in our community. So I'd just like to acknowledge all the study participants and the health services who've been involved in this, my fieldwork team and all of the chief investigators and interstate collaborators, especially Amy Peacock, who's leading a lot of this fantastic work that's going on. So on that note, I'll end and take any questions if we have time.
It's my pleasure now to introduce Dr Nicholas Thomson from who's located in Adelaide. So we'll get Nick up on the screen.
G'day, Peter.
G'day, mate. So Nick's based at the London School of Hygiene and Tropical Medicine. I can't think of a better place to be than the London School of Hygiene and Tropical Medicine. I've never worked at anywhere so interesting as that. And he's involved in a large research project exploring opportunities for transitioning from war to peace in the context of illicit drug economics in Myanmar, Afghanistan and Colombia. He is mainly focused on Myanmar site and a large-scale methamphetamine and heroin production in the Kachin and Shan states. Its connection to ongoing conflicts and its implications for widespread drug use and how health responses such as harm reduction can function and expand to scale in its complicated environments. And so putting that into context, if you think about the problems we've got in North Richmond, that puts harm reduction in a whole different sort of context when you think about harm reduction in the context of the war in Afghanistan and conflicts in Myanmar. So Nick's working with multi-agency group and also in Frankston, which brings it back to home in partnership with the department and local government and the healthcare providers down there. It works with a range of efforts to improve access to services and reduce vulnerability to alcohol and drug harms. Nick has a long-term interest in how different stakeholders across the health, security and broader community can better support harm reduction and its ability to expand its repertoire of activities and push out further the margins of its influence. So Nick's talk is going to be from global to local. Can COVID be a game changer to re-energise the harm reduction? And when I've been talking to Nick, one of the things that we've talked about is that harm reduction in many ways can be seen to have been stuck in the 80s. And the harm reduction had its heyday in the 80s and the early 90s. And COVID has presented a lot of challenges. And so Nick has been charged with really thinking about what it's going to look like going forward. And as I said to John Fain at our annual meeting, you can go a bit Old Testament and prophet on this, Nick, and give us your best shot. So welcome, Nick.
Thanks very much, Peter. Can I just make sure everyone can see the screen and it's at the appropriate scale, etc.? Excellent. Thanks a lot for the opportunity, and also just like Paul and also like Peter, I just want to acknowledge that I am speaking from Adelaide, which is Ghana country, and country that it's a magnificent part of the world, and certainly country that was also never ceded. And I really appreciate also the comment, Peter, around your understanding and around these kind of cultural attitudes, and perceptions changing to re-energise and reconnect with our Indigenous cultures, and I'm fully supportive of that. And so just a quick story on the London School of Hygiene and Tropical Medicine, which in many ways is a benchmark particularly for responding to pandemics, and a quick story about being over there around the 20th of March, having been imported to get to London and getting there. And I work with a number of groups there. I work with a sociology, qualitative health research group, and I also work with an epidemiological epi team. And the sociology team was saying, Nick, it's fantastic that you're here. Absolutely, we're delighted about it. And my epidemiology colleagues were saying, what the F are you doing here? You need to get out of here. There's a global pandemic, don't you know? So within universities and within all kind of, and within governments and within many platforms of life, there is always a contested perspective about what is going on. And if one of the things that we've been able to learn from COVID-19 is in places where the science prevails and governments are taking science on board, you tend to go a whole lot better. And that's been obviously widely demonstrated in terms of the Australian response vis-a-vis the European, vis-a-vis the US response particularly, but we can talk around another responses as well. So Peter asked me to kind of get a little Old Testament. I had to ask him what the Old Testament was. So I'll just foreground my agnostic perspective versus my religious one. But can COVID be a game changer and re-energise harm reduction? And I'll speak off the cuff largely, but just want to give a couple of global kind of snapshots. COVID-19 harm reduction alert. So this was a piece of work that was put out by the by Input, the injecting network of people. The international network of people who use drugs. And I think what's been really interesting with harm reduction globally, in all the things that I've been reading in preparation for today, is how mobilised and how engaged networks of people who use drugs have become, and how increasingly important. Well, obviously always been important, but increasingly vocal and increasingly recognised for how important they are in terms of reaching people, and particularly in areas where shutdowns have been extreme. So I just wanted to kind of acknowledge that. This is a slide from a report that a friend of mine did that was published in Harm Reduction Journal as well. This is from Pretoria. And the point of this slide is that when COVID-19 really took off in South Africa, they were extremely concerned about people with unstable housing and homelessness. And they converted a stadium, the Pretoria Stadium, into a homelessness shelter / COVID testing site / methadone access, opiate substitution therapy access. And so within a couple of thousand people who were situated in the stadium and put into Pretoria, they really mobilised a methadone maintenance program for about 200 people, and they did it relatively quickly. Some key lessons learned out of that was, the value of communicating with people directly affected, and the value of methadone to reduce harms, particularly in the context of an absolute emergency. Now, this is the good part of the story. The other part of the story were that conditions remained fairly difficult for a large number of people. People felt trapped in there. A lot of people tried to escape. But what it did lead to was this notion and discussion around homelessness and housing more generally, and the intersection of housing, homelessness, and drug use, housing, homelessness, drug use, methadone, and COVID. And I think that has really been something that I've seen in a couple of other parts of the world as well, where we're starting to see not only kind of discussions around the need to integrate harm reduction and services for people in unstable housing, but the actual implementation and real kind of considerations around that. And I think that, that is to credit of all involved. This is a slide that just came out recently from some people in Spain, talking about what was happening in Spain. And it's a snapshot, obviously, and I'm putting it up there just to kind of highlight some of the things that happened to a whole range of services and people are accessing services in Spain. And I think what's really interesting here is that many people found it more difficult to access services, although accessing drug use became a little bit harder, not actually that much harder. But it was actually accessing people and accessing people who could give services became more difficult. And overall, the 40% drop in service access during the lockdown period of 3 or 4 months compared to the previous year before. So this is kind of just to say that, this is just snapshots and quick snapshots without general context. But some services have been able to kind of maintain their service access, and other services in different parts of the world have not. And so we're not seeing a homogenous kind of response here. And I think, again, grateful for the public health work and the harm reduction work that all the players in Australia do, because it's been a triumph in many ways throughout these difficulties. And I think when you take it into different contexts in the world, you work out how lucky we truly are. I just put this, as we kind of go around the world here, this is what's happening in Central Asia at the moment, where what we saw in Central Asia, what we've been seeing in Central Asia is demand for services, particularly online services, has increased significantly. People, like Paul was saying, that access to drugs has also become a little bit more difficult. And one particular study found that the need for kind of broader social determinant type services like housing, like transport, like food, increased significantly. So again, what COVID has highlighted, particularly for people who are using drugs, is that there are a range of other situations going on that potentially might not have been highlighted, without COVID kind of restrictions, even though we've kind of known for a long time that these things are happening and people are suffering, multiple comorbidities in terms of structural issues at the same time. So just to kind of give a bit of a snapshot around the world, and just this, I've kind of got this slide in there for a couple of reasons. This is a slide from Kachin State in Myanmar, or not in Kachin State, but most of the drugs are being produced up there, and Shan State. This is the Myanmar government, the Tatmadaw, the military, burning off tons and tons of stimulants. And so there's a couple of points here. One is that drug production in northern Shan and Kachin State increased during COVID restrictions and the COVID pandemic more generally. The second point to make here is that they are producing exponentially more crystal methamphetamine than they were producing 10 years ago and 10 years before that. And there's been a massive kind of a glut of methamphetamine, and that is kind of seeping into local use quite significantly, particularly in Myanmar, but also across the region. And just while I'm at it, we've also seen a shift in drug markets in a story we released last week, which I can point people to, around the transition to Afghan methamphetamine production and the potential large-scale crystal methamphetamine production being made out of ephedra plants, so plant-based methamphetamine crystal coming online out of Afghanistan. So what we're potentially going to be seeing is a merging of crystal methamphetamine markets. And we were on a call last week with the AFP, briefing them about the potentiality of that for Australia, because they've already found plant-based methamphetamine here in Australia, in Adelaide particularly, but also in other places. And so what that means for law enforcement systems and health systems and harm reduction in general is a question, and we can kind of come back to that. Just focusing back onto Kachin State for 1 second, one of the things that we did see in the lockdowns in Kachin State through the Asian Harm Reduction Network discussions is that OST, opiate, methadone take-home services, which people have been advocating for a long, long time in Myanmar, were actually mobilised. And this is a fantastic innovation, and it's gone okay. Now, people are familiar with the Myanmar context. I know Paul is, and probably others as well. The scale of need in northern Myanmar is unprecedented. So anything which advances access, such as take-home methadone, is to be considered an advance and an innovation. How we protect these things going forward and how we continue to expand opportunities of service access in really, really difficult parts of the world is really an opportunity for harm reduction and for harm reduction to kind of take on board. And one of the things that I think is important here is can harm reduction be a game changer? Can harm reduction actually be a bridge to peace? And if you were to ask me, if there was a COVID vaccine, if there was, who would imagine a COVID vaccine that was actually ready to be delivered, and you could guarantee -80 cold chain on the Thai-Myanmar border, how would you distribute something like that to hard-to-reach populations across northern Shan and Kachin State? If you were the World Health Organization advising the Ministry of Health in Myanmar, which has no authority in many parts of Myanmar, particularly in the ethnic armed areas and the conflict areas. So the only way that you would actually be able to do that would be to engage in discussions with generals of ethnic armed organisations. And I think my point here is that if we coming from a health background, if harm reduction is a health-based opportunity, how does it actually mainstream itself and take itself further? And I think part of that discussion, certainly in Myanmar and other parts of the world, is how you engage with different forms of authority and different forms of local authority particularly. And I think, in Australia, we're obviously extremely lucky. We have health systems that are functional and largely left alone, although I'm picking up on Paul's point around deleterious police interactions in Melbourne during this lockdown. But I think these are the real opportunities. So harm reduction as a bridge to peace, who would have thought? But I think, there's some exciting times there and opportunities if we're willing to kind of take them. So just kind of returning to some more local work that I've been involved in and peripherally, if so, as well. So where are the opportunities to innovate harm reduction? I just want to talk really quickly to Frankston, because we've been working down there for 4 or 5 years now on this multi-agency project. And the breadth of our project is really around reducing harmful alcohol and drug use amongst young people, and particularly amongst people that are non-injecting drug users. And part of this is a perception piece around Frankston, where many people, whether you're sitting in the city of Melbourne or you're sitting down in Sorrento, a lot of people have assumptions about Frankston and assumptions about what is happening down there on the train station or other places. And the reality, one of my colleagues, Kirsty Morgan, who's a terrific colleague and researcher, spent 200 hours on the Frankston train station a couple of years ago talking to all sorts of people about what was happening down there. And as it turned out, there was really limited drug use and substance use amongst the population who were gathering around the train station. But the assumption was that, and the assumption remains that it's a drug hotspot, and it may well be a drug hotspot, but there's different types of networks and cohorts of people using, and what they're using is different. And I think it's important to kind of ensure that when we're telling stories around what's happening, that we're actually telling it from what's really happening rather than reinforcing assumptions. So just on that, there's a couple of things that we've been working on which we think are hopefully starting to push the boundaries of harm reduction a little bit further. If we consider harm reduction as a term, as a definition, when people ask you what harm reduction is and you say, well, it's responses to injecting drug use, it's HIV prevention, it's bloodborne viruses, it's access to primary health care, et cetera, et cetera, et cetera. it still remains, to my mind, a fairly narrow definition and narrowly shared and narrowly appreciated by a percentage of the population. So the challenge, I think, is to expand its access, to expand the grasp with which it takes in people's own thinking, because I think this is a mainstream public health intervention, harm reduction is, and it should be mainstream and it should be more broadly accepted and implemented and resourced. And it should be able to expand itself into a whole range of other areas that it currently hasn't been working in. One of those areas, I think, is with police, and picking up on Paul's point. And so our project down there has been, we have police on our steering group, and there's been no shortage of efforts to engage with police around harm reduction across Australia more generally, not interrupting and interfering with needle syringe exchange programs, et cetera. So we put together what we call the PACER Plus program. People might be familiar with PACER around, partnering up of health professionals or mental health experts with police. We could have put a different tweak on that, and we had people with lived experience of alcohol and drug use accessing, going out with police from Frankston Police Station as secondary responders when first responders were calling into the police station saying we believe there might be an alcohol and drug association of this potential call out. Now, it took us months to get this program off the ground. We had a whole range of very expected issues, like half the police not really wanting to have people with lived experience of alcohol and drugs accessing the police station, and police certainly not wanting to be driven around in cars by people with lived experience of alcohol and drugs. All of those things aside, when we finally got through it all, the program itself was able to actually run for 3 months in terms of an implementation phase. So 18 months of work for 3 months of action. And in that 3 months, 54 people were accessed through secondary call out by the person with lived experience of alcohol and drugs. 53 of them were referred to services, alcohol and drug related services, who had never accessed services before. And of those 53 people, not a single one, up until the end of the evaluation, not a single one had been involved in any kind of police call out or charged with any police related or offence by the police having accessed that program. So the program got shut down eventually when the police union stepped in and said that it was a danger to have police not doubling up and et cetera, et cetera. But the program was successful, and the evidence would suggest that it was keeping people out of criminal justice systems, and it was also accessing people to services, which is exactly what you want your harm reduction expansion ideas to be thinking about. Secondly, there's the other thing that is going on right now in terms of the design with colleagues from Newark and Susie Nelson and others, people might know her. We've been designing a program looking at a shared care model between GPs and pharmacists in terms of opiate substitution or opiate maintenance therapy. As many people know, the pharmacists and the Pharmacy Guild and the pharmacy associations for a long time have been advocating that they can do more in the space, working with people that use drugs. There's been tensions there between the AMA and the government, who's going to pay for this and what's it going to look like, and et cetera, et cetera. But so down in Frankston, we have an agreement, not an agreement, we have a program of work being developed that will design the model that will see a shared care management between GPs and pharmacists. And it's going very, very well. And we have a clinical reference group, which has representatives from the department, also the AMA and other locations. So it's very rigid in terms of its design. It's very tight. It's very risk averse. But the bottom line is that we are moving to a space where we'll be able to trial a shared care model between GPs and pharmacists, which will open up more opportunities for people to access services when they need them, and without some of the barriers that they face at the moment. So we think this, again, is an opportunity, an innovation opportunity. It's expanding the discourse opportunity. It's bringing more players into what is essentially a harm reduction framework. So I kind of want to finish by posing some questions. And I've said, from marginal to the mainstream, and people might not necessarily agree with the way I'm framing this. But having been involved in harm reduction for a relatively long time, in different parts of the world and the like, I've always been struck by how proud harm reduction people are, and the people that work in the space are, but also how protective in many ways we are of the space as well. And if you go to some of the conferences, which a lot of us do, there's a sense that we're proud of how kind of innovative and marginal we kind of are in this particular space, because we're working with people that are using drugs. Drugs are often illegal, et cetera, et cetera, et cetera. And I think in some ways that it kind of limits the audience that we speak to, and it limits the ability to kind of mainstream this more generally. And I'm talking from personal experience in different parts of the world, not necessarily from Melbourne, I must say. But I do know that I've, having spoken with, government representatives from different parts of Asia, particularly, if you rock into a harm reduction conference and you're seeing the celebration of harm reduction and the celebration of people and their drug use, et cetera, it's not easy for people in different parts of government to say, oh, this is fantastic, let's mainstream and expand this. And I think it's more for us to be kind of cognizant on, in terms of how we continue to evolve harm reduction and the discussions that go with it. So, how does harm reduction expand itself from its current operating perspective to become more mainstream public health and public policy? And from an Australian perspective, I think we obviously do well in a whole range of public health areas. Can we do better? Can harm reduction and its public health outcomes be embedded more in the core responsibility of everyone's business? And I say this when I look at the national drug policy frameworks, and this idea that harm reduction, drug supply reduction, drug demand reduction. I was chatting with Peter the other day. When you see that kind of that the unholy trinity of drug policy in Australia, if you're a harm reduction public health person, you see harm reduction, you go, okay, fantastic. If you're a police officer, you see supply reduction, and you see, okay, well, that's my piece of it. So how do you ensure that the supply reduction, the people involved in that, they're also really taking on board their role in harm reduction? And to Paul's point, really, about police interventions and police interactions, and if we're still seeing too many negative police interactions in the context of people are accessing services, one is too many. So I think there's room there to ensure and embed harm reduction as a principle to become other people's core business, not necessarily just the people running the programs. So where are the opportunities to reframe this locally and globally? I'm always struck, particularly in Asia, about the lack of harm reduction interventions and initiatives in the context of methamphetamine and non-injecting methamphetamine use. And I say this, speaking from a region where harm reduction programming and funding is tight. The people that are running programs are designing and running programs over a number of years from a bloodborne virus prevention perspective, using outreach teams that have histories of injecting drug use. And there are a whole range of cohorts of populations of people out there that aren't injecting but are still using an enormous amount of drugs in different ways, and particularly in Asia, having really negative interactions with criminal justice systems because of it. And so for me, I think there's real opportunities that remain in drug policy and drug policy reform, but not only in drug policy reform, in terms of how criminal justice systems and how communities understand the ideals of harm reduction in a broader sense, particularly in non-injecting amphetamine, if I'm particularly talking about Asia. So has COVID-19 provided a catalyst for reframing of harm reduction? And I think, if you look at some of the innovations that have happened, particularly in the Victorian context, and the way people, Paul's point around service pivoting has been unbelievable. And I think it just goes to show that when the shackles are off and the pressure is on, what can you do? And I think, we need to protect the innovations and the reforms that have come, and I'm sure Gary can speak to that more generally. But I certainly see that everything has changed now. And so this is the time, if we're going to continue to drive reform to reframe harm reduction and expand its purview, this is really the time. So I think we should be thinking about that. And I just to finish, because I've been doing some work on this, from bloodborne viruses to integrated housing. And I think the idea that, I think what we saw, particularly in the US and San Francisco early on, and certainly in Melbourne and other places, it was the people who were the most vulnerable to unstable housing, who are often the most vulnerable to narratives around drug use as well. And by seeing the blending of service provision for people who use drugs with the ideals of integrated housing, we're starting to really put it out there that the social determinants, for want of a better term, are the social determinants and remain critical. So if we can mainstream harm reduction within these broader social determinants, I think we're going to win. So innovation here to stay, is it here? So some this is from Harm Reduction International, some of their recommendations. COVID-19 adaptations in some ways have increased access to services, so they should remain, as I just said. A recognition of task shifting, and particularly this is involving peer involvement and peer interventions and outreach workers. I think if we didn't know it already, peer networks and outreach teams who are of these networks are absolutely critical. They've been standing up and they've been delivering from the local to the global on messaging. So we should continue to invest in their capacity at every opportunity. And finally, my pet issue, obviously, the interface of health and law enforcement and community, and what does it look like? And I would hope that with our sustained ideals of engagement, that harm reduction can be a bridge for not only peace but for better public health across a range of issues, and indeed equity and the sustaining of human rights in places where they're not recognised. Thanks very much, Peter. Thanks, Nick. I'll leave it there.
Well, thanks, Nick. That's given us a lot to think about, and I think Paul and Nick have given us a very broad perspective from the local around data, around trends of use through to international movements and challenges. And I think my reflection is that a lot of the information that Nick has just shared really brings home there's so much intersection between the work that goes on in Melbourne and some of the challenges that are being faced internationally. We really are in a global village of harm reduction. Now, it's with great pleasure I invite to get back to another local perspective, but this from a government and a department perspective, to introduce Mr. Gary Morris. He's the Manager of Alcohol and Drug Services Development Design. And Gary's got carriage of a lot of issues. I've seen Gary in many meetings talking about everything from rolling out information campaigns around COVID-19 and trying to think about how to maintain opiate replacement therapies for people in homelessness situations. And Gary's going to be talking to us about progress around the naloxone legislation change, public drunkenness activity, and also the proposed new injecting rooms. So welcome, Gary, and it's great to have you here.
Great. Thanks very much, Peter, and thanks very much for the opportunity to provide an update on the department's harm reduction initiatives. I'd just also like to acknowledge the traditional owners, protectors of the earth, skies, waters, on where I'm speaking from today, and acknowledge the great work that they've done. Just starting off, I might start with the medically supervised injecting room, and hopefully the talk that I give today is as informative as the other presenters. And I find it very refreshing that I'm not talking about COVID-19 directly. So in relation to the medical supervised injecting room, the government's engaged Ken Lay, as you're probably aware, to lead a consultation progress for a second supervised injecting room, and that is to be based in the city of Melbourne. Mr. Lay will report to government on the site and the actions to support safe and amenity for the service. Mr. Lay is working with health and drug reform experts currently to analyse data and evidence on drug harms within the city of Melbourne and oversee a fairly comprehensive engagement process, seeking the views of interested parties on a preferred site. It's important to note that this includes clients, services, community representatives, business, and a lot of other key stakeholders. This consultation process will consider drug activity and harms, existing health and social services, safety and amenity, transport options, policing and infrastructure requirements. He's been pretty busy, Mr. Lay. As of to date, he's met with 103 stakeholders over 43 sessions during an initial phase of consultation. And this is focused on gauging the views of health and drug reform experts and institutional representatives of Victoria Police, Ambulance Victoria and such. He's also heard the views of CBD clients and services, traders from the Queen Victoria market and residents who live within the vicinity of what is the preferred site at 53 Victoria Street. Just want to thank everyone who's already been involved in this consultation process to date. Just want to also point out that you can register via the department's website to get project updates, including opportunities to participate in the consultation. I would assume that a lot of people have already signed up to that, but if you haven't registered, I'd encourage you to do so, and please feel free to participate in that consultation process. The second scheduling of the consultation process will begin shortly. This will prioritise community views, will include clients, residents and businesses. The work will then be collated and a report presented to the Minister for Health by the end of this year. The Victorian Government decision on the services location will be informed on the advice that Mr. Lay presents. So that's the update on the medical supervised injecting room. So it's really good to know that COVID hasn't had an impact on the important work that's being progressed on that. In relation to decriminalisation of public drunkenness, for those who aren't aware, the government is committed to repealing public drunkenness offences and replacing them with public health responses to support people who are intoxicated in public. The decision came about, as most people are probably aware, of the context of the tragic death of the Yorta woman Tanya Day and the subsequent coronial inquest, which made recommendations to government. There's been an expert reference group, and that's reported to the Attorney General on the best way to implement the reforms. It's worth noting the members of that group were Helen Kennedy, ex-Facho, Narita Waite, Aboriginal Legal Service, Tony Nicholson, the ex-Brotherhood of St Lawrence, and Jack Blaney, who's ex-VicPol. The expert reference group recommended that police's role be minimalised as much as possible in the new health model that's being developed, and that outreach, transport and sobering up services form the core of the health response. This will ensure people can access a place of safety and recover from intoxication, while also having the opportunity to engage with follow-up wraparound services such as AAD, mental health, housing and family violence support. Given the scale and the complexity of this reform, the expert reference group recommended a transitional period where the health model is trialled in key areas of the state, with the health model rolled out statewide within 2 years. The government published the expert report on the 28th of November alongside a government response. The response supported the expert reference group's reform framework, but noted some of the specific recommendations will need to be worked through with stakeholders throughout this implementation period. So it's worth noting that where we find ourselves moving forward is that the government remains committed to introducing repeal legislation to Parliament by the end of the year. 16 million has been allocated in the 2020-21 state budget to kickstart the implementation of this reform. The key next steps are to consult on where the trials will be located and work with local stakeholders to determine what sorts of services should be included in the trials based on the expert reference group report. Department of Justice and Community Safety and DHHS are leading these reforms, with DHHS leading development of the health model. There will be further consultation with health sector stakeholders in the coming months as the trials are developed. It is worth noting that when I refer to DHHS, I'm probably now referring to the new Department of Health, which will be implemented by the 1st of February. So just making note of the machine of government changes that were announced last week. Finally, moving on to the other initiative, which is really important, is the naloxone and secondary NSP distribution bill. This bill proposed amendments to the Drug, Poisons and Controlled Substances Act and was introduced to Parliament in October. The bill will address escalating harms from the use of illicit and pharmaceutical drugs by creating a power to make regulations about the supply, possession and use of naloxone and legalise the secondary distribution of sterile injecting equipment. These measures will enable delivery of government commitments in response to the 2018 Victorian Parliamentary Inquiry into drug reform. These being to allow health workers and needle and syringe programs to directly dispense naloxone to clients who are at risk or who may witness an opioid overdose, enhance the role of peers in naloxone programs, and remove the restrictions on peer distribution of sterile injecting equipment. The bill will allow people other than pharmacists to seek authorisation to supply naloxone to people who are at risk of or who may witness an overdose. This will also include health workers in needle and syringe programs and potentially other organisations that intersect closely with people who use opioids, including services such as alcohol and drug treatment providers and through them peers. Assume the bill passes successfully, supporting regulations will need to be made, and we estimate that these new arrangements will come into effect within the next 6-month period. So that sums up those 3 really important initiatives that the department are currently progressing. Peter.
Thanks, Gary. Look, there was one other thing I was going to ask you, Gary. Amanda mentioned in a meeting we were in the other day about the review around harm reduction. You're employing a consultant that was doing a review around harm reduction services or in terms of needle and syringe exchange programs?
At the moment, what we're doing is, as you know, the department did a reorganisation at the start of the year between policy and the commissioning areas.
Yep.
We didn't really get the opportunity to bed a lot of the work down that we were hoping to progress and sort of plan and be strategic because of a little thing called COVID-19, which had a bit of an impact on our workload. So we're coming back and reviewing that. One of the things we're looking at doing is the harm reduction portfolio has moved into the commissioning area, which I have oversight, and Amanda's been leading that work and doing a fantastic job. And currently we've just really getting our heads around and ticking over where things are at. But going forward, we see harm reduction as a lot of little initiatives at a whole heap of places. So funding wise and the like. So we're looking at how can we sort of enhance that value, have better outputs and better outcomes. So that's something we'll be sort of looking in the terms of the new commissioning model that we have. In terms of the NSP, that's something that's being explored at the moment. So acknowledging that the NSP sort of program's been out there for quite a number of years and really hasn't had really a big spotlight on it. I think it'd be fair to say for a while. And that's something we're sort of looking at the moment is how do we do the business and how can we sort of enhance that or, do a better job going forward. So look, it's exciting times in the department at the moment, Peter.
Thanks, Gary. I didn't mean to throw a hand grenade. But
that's all right. Happy to catch it.
No, good on you, buddy. Catch it. We might go back to everybody now. So, look, we've had a fantastic presentations from our 3 speakers. And best way to do this, are there any questions that people have for any of the speakers? So either through the chat room or you can jump on board and ask a question. I've got one that I'll kick us off with for Paul. Paul, is any of the data that you've collected, the COVID data, has anything stood out to you or surprised you in terms of the data that you picked up through the reporting systems that you've been looking at? Is there any trend there that you think is noteworthy?
In some respects, the things that we've seen that haven't changed has sort of surprised me a lot. I mean, I know that and we haven't analysed this yet, but the heroin supply really did seem to sort of decrease as you would have expected, but then seems to be starting to rebound now. So monitoring that's going to be really important. But for me, the thing that's still really troubling is just that differential enforcement of fines. And I guess I kind of expected to see something like that, but I wasn't expecting it to see for it to be quite so dramatic. And it's really concerning, and hopefully there'll be some way of sort of mitigating the effects of those fines if we can. But yeah, that's probably the fundamental.
There's also been a question about the availability of your presentations, Nick and Paul. Will they be made available so we can put them on our website?
So there's a couple of, I'd probably prefer just to point people to the bulletins that things are presented in. So a lot of that, a lot of the information is in those bulletins and they're published. So that probably makes more sense because they're better presented.
Okay.
Yeah, I'm happy to make a couple of adjustments to mine and make it available to your listeners. Thanks. No problem.
Gary, there's a question in our chat room. Have you seen that?
I did. I noticed Brad's comment and the questions building on the themes raised by Paul and Nick's talks, where he says access to take-home doses was increased for people on opiate replacement therapy during the lockdowns. Will these changes be maintained? We're starting to experience some pushback from pharmacies on a number of take-home doses. So, look, I'm happy to take that on board and sort of follow that up, Brad, and look at the intelligence we're getting. Obviously, we've changed some of the guidelines in relation to opiate replacement therapy, and we're keen for those guidelines to continue. So that's something we'll sort of be monitoring, and I'm certainly happy to follow up. But if there's additional information pertaining to specific areas or issues, as always, please feel free to email me or give me a call, and I'm happy to discuss it further in more detail.
Here we go. Sam, this is from Sam, the PACER scheme. Nick, can you see that question there?
Yeah, I can see the question. Paul lauds the PACER scheme and the way it works with people with mental illness. I remain perplexed why a similar scheme working with people badly affected by drugs and which on all accounts seem to be working should not be supported by the Police Association, who I would have thought should be, but who I would have thought should be separate from direct operational decision making. Great question, Sam. And I can't talk to the inner machinations of the police union association, but I mean, reflecting on the experience of advocating for the PACER Plus program to get off the ground through Peninsula Health. And there was a couple of things that I think we could have done better. One of the real concerns was that you had people with lived experience of alcohol and drugs driving police around in non-police cars. Now, to me, that didn't seem like something that we should have really pushed hard on. I don't think we really did push hard on. I think it was really just in a program design. It should probably never have got through. I don't think there's any reason why why police couldn't have been driving, and so why people couldn't have. Then that would have taken it off the agenda. But to me, it seemed that there was a couple of people within Frankston Police Station who at the time might not have been supportive of the program, and they might have had discussions with their counterparts at the association. And once things are flagged, you only have to, things only have to stop for a couple of months, and then the funding's finished anyway. So, yeah, I mean, we were disappointed. I think it could have been handled better. But I think there's a lot of interest in the fact that we got this far with it, and it appeared to have some really positive impact. So I think we should pick it up. And I'm happy to talk to you about it, Sam, offline.
Here we go from Maria. Hi, Gary. Are you able to provide us with where you would see service demand at the moment due to COVID-19 and the programs being considered to support people in need? So you got the gist of that, Gary?
I have got the gist of that. Thanks very much for your question, Maria, and thanks, Peter. Yeah, look, COVID-19 has certainly put a significant strain and impact on what is a system that is already under strain at the best of times, and it certainly has impacted in relation to withdrawal and residential services due to implementation of social distancing and other measures. They're obviously unable to operate at peak efficiency, and that has an impact on waiting lists, but also has an impact right throughout the AOD service system. Look, it'd be remiss of me not to, before I go on any further, just to call out the fantastic work that agencies have done during what can only be an unprecedented and trying time, and a very difficult time for everyone. And it's been remarkable and highly commendable the way that services have stood up and continued to provide the important services they have for the clients. So I just want to give a call out to everyone for that really hard work. It is a concern for us. We are looking, as we speak, doing a whole heap of budget bids and working behind the scenes to try and look in ways in which we can advocate on behalf of the sector with government and to get additional funding and look at measures that we're looking at. Things we're looking at the moment is looking at around outreach services is potentially one area we're looking at, potentially the way in which we can look at supporting people while they're on wait lists and provide more therapeutic inputs during that sort of period. Also acknowledge in the budget that there was an additional funding for an additional 100 AOD advanced senior clinicians. So that's something we're working with the workforce area within the department. So there's a number of things we're trying to do to, I guess, try and mitigate against, the increasing demand we have for services.
Yeah, thanks, Gary. I might ask Nick and Paul another question. Is there anywhere that you guys could think about around the world where you think that harm reduction has been taken to a different level, that Australia could really turn its eye and think about looking at? Because we used to be world leaders 20 or 30 years ago in harm reduction. Where's the real cutting edge around harm reduction thinking and practice now, internationally?
I'll jump in quickly. I mean, I think in parts of Canada where they really do have a opioid overdose crisis, they've led sort of a whole range of innovative approaches that include a lot of consumer involvement, which is really important, which Nick was pointing to earlier. It looks like I think they're about to decriminalise possession of all drugs in British Columbia. We know that cannabis has recently been legalised in the whole of Canada. That's recreational use, which is one of the few countries in the world where it's actually legalised. So I would have put Canada at the forefront, but they've got a they've got a step change in terms of the problem compared to what we have. We really, there's a range of data out there at the moment that shows that opioid overdose for us during COVID has actually declined, and yes, declined quite a lot. None of that's been properly written up yet, though. But in Vancouver recently, or in British Columbia recently, they had their peak number of opioid overdoses for a given month of any month. and that's sort of after the COVID restrictions that they've got in Canada, and their numbers are dramatically higher than here, in spite of the similar kind of population to the whole of Melbourne. So it's a huge tragedy, but they are leading the way in making pharmacotherapy more accessible. So they've got vending machines now for dispensing of pharmacotherapy. It's not, basically it's complicated and it's not sort of widely adopted, but it actually allows for a scale up of distributing things other than sort of methadone and buprenorphine. And in this case, it's hydromorphone. So, I'd point to Canada as a leader, but there's lots of other innovations, and we are slowly getting around to pursuing them. There's likely to be injectable opioids trialled in parts of Australia soon enough, and we'll see what happens there. We've obviously got a second supervised injecting facility that will be opening up, which is a major step forward. It's a huge coup for the government. So I don't think we're in the backwater anymore, Peter, is what I'm saying.
Great. Nick?
Just to add some thoughts, really. I mean, Paul's kind of laid out the Vancouver experience particularly. And I think, when you're sitting there on the west coast of Canada and you're getting hit by fentanyl storms as well, that really does force the issue particularly with regards to naloxone. But I would speak to a kind of a broader idea around innovation in general and how harm reduction programs innovate in general. And I don't think there's not a huge amount written about how harm reduction actually gets done. So we see the policies, we see the funding streams come, we see programs expanding or second needle safe injecting facilities kind of coming together. But what we don't see or read about is how it actually happens, the politics of making something happen from an outreach program level to a program management level to a kind of a more funding level. And it kind of makes me think that this is a gap, I think, in how we understand harm reduction. We see it happening, but we don't understand how it's managed to transition itself from, in some parts of the world, from nothing to something in relatively short periods of time. And I think there's an enormous amount of unbelievable work that has gone on by individuals who are taking these issues on. So I think part of the story is to unpack that further and to demonstrate the enormous kind of bravery and resilience of programs and efforts and peers to drive service provision full stop in really difficult circumstances. And I think if we were to appreciate those stories for what they are, which are kind of triumphs of public health and human rights endeavour, then that would lead us to situations where where it's more acceptable and mainstreamed, and people are more proud of it. And I think the other thing which kind of really strikes at me as being something that we kind of all need to take on board is if you go to particular, not speaking from an Australian perspective, but if we go to certain countries in the world, the discourse around harm reduction happens between the programs and the government. It doesn't really happen outside of that. And the program recipients, obviously. And so I think there's huge gaps in mainstream media support for and understanding of approaching drug issues from a range of perspectives. I think we get the odd story, and to be fair, in Australia, the Fairfax and the Murdoch support for the safe injecting facilities was one of those examples. But taking that to the Bangkok Post or some of the Myanmar, the new light of Myanmar, for example, is a different story. And I think efforts that allow us to work more closely with generating different understandings of what it means to respond to drug issues at a community level would be really valuable.
Okay. Well, I think we've, unless there are any more questions, are there any more questions from anybody within the audience? Well, look, on behalf of everybody, I'd like to I don't know how we do this with everyone's cameras off, acknowledge the contributions both of Paul, Nick and Gary today. Thank you very, very much for your efforts today. And so we're all,
video and likes on, and we can do a quick round of applause. We're all
doing our thing and with our hands and clapping and all that. But we really do appreciate your presentations today. And we are so lucky in our sector in this country to have people of your eminence and intelligence and passion and dedication. And I, for one, have been a beneficiary of your wisdom and your expertise for many decades. So thank you all for your contribution today. And I'd also like to, on behalf of the Yarra Drug and Health Forum and everyone here, acknowledge the work of the executive of the forum. And I'd like to thank Mr. Nick Wallace for so skillfully doing the IT work in the background. Thank you, Nick. And I'd like to thank Bernadette for her...
my internet died in the middle then.
Well, we weren't going to mention that, Nick. And I'd also like to again acknowledge the work of our executive officer, Ms. Bernadette Birchall, and she's completed a fantastic COVID year of work on behalf of the forum. And I'd encourage people to participate in the forum, and there are seats on the executive for those who are interested in being part of the executive. Please make yourself known to Bernadette through our website or through email or whatever if you are interested in joining. So on behalf of everybody in the forum, we wish you a safe summer and good holidays, and hope you and your loved ones and your families are safe and well over this period of time. And thank you for joining us today. So thanks very much, everybody. Cheers. Thank you.